Hi, I'm Dr. Raja Quiller. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics. Welcome to my series of online training webinars. So remember, the first point here is 1 centimetre above the inferior border of the zygomatic arch, and typically I would say 1 centimetre in front of the hairline, because at the end of the day it's surface anatomy, isn't it? I grab the skin over the top of the zygomatic arch to make sure that I'm on the arch and it's not moving. And then I'm going to retract like this, because this is the desired vector of lift. Look at her nasolabial fold, how it starts to get better. Look at how the lateral lid cheek junction and the lateral canthus is influenced by this mechanism of lifting. So why don't we use this approach? Take the product, we go through the skin and then onto the periosteum here. And you see how the skin is now stuck behind the needle. So I make my nice big aspiration, there's the bubble. And then I'm going to inject 0.1 to 0.2 cc. And the point of this is to give her slightly lateral projection, but also to start that adhesion and sticking process. So that was 0.2. And then as I come out, you'll see how, watch the skin, it doesn't fall back forward as much as I pulled it back. It already got stuck on top of the product. Then I take the product, and look, this is very interesting. That's the dot where I went in, but look, the product is actually sitting behind because the skin flopped over the top of it and it left it here. So now I'm going to stick the skin back into the correct anatomical position to try and generate the lift for her. And what I'm doing is I'm just squishing the product so that the skin can attach to it, and I know that it's done when I can't feel a bolus of material. Now, I talked about the first point and the second point, but actually between the two, there's sometimes a division in the lateral and the central malar fat compartments. So in this situation, then I'll go in just in anterior to it and do a second injection. But again, look, my non-dominant index finger is on the inferior border of the zygoma. And then I'm going to inject again onto the periosteum. Fix with the other hand. Always make a nice big aspiration with the bubble. And then we can safely inject. So after this training session, I would love you all to start using two-handed fixed aspiration if possible. So again, we're going to do 0.2 cc. And we start to see not just projection, but also we should start to see lifting. Because I'm going to take the skin again and watch. I'm going to now mold laterally. I'm also going to start to mold superiorly. Because in molding superiorly, what I'm doing is I'm starting to affect the lateral lid cheek junction here. And after these 2 points, we can start to see whether or not there's any improvement to the appearance of the eye. Thank you. So, look at the camera, the red light. Perfect. Now, can you all see that on this side, she has a descent of the corner of the eye. This is the first negative facial vector. And also she has a tear trough appearing, that the eye falls down slightly on this side, and whereas on this side now, she's much more open without the need to inject directly into the lateral lid cheek junction. Whereas on this side here, you can see that she has a cavity there. And also you see the lateral lid cheek groove. And on this side, it's gone. And we didn't need to inject it already directly with the needle. Now have a look at the two eyes together, and you can start to see that her left eye just looks more appealing. It's more open, it's more beautiful, it's also more youthful. So we already hit outside of the box in terms of what we're able to achieve by injecting using an indirect mechanism. Now let's try and influence the anatomical tear trough by injecting into the SOOF. So here, I'm just going to test now. This point, it does help. This point helps hugely, doesn't it? Look how it reduces the tear trough when I do this. So we know that this is going to be the next injection spot. Thank you. So we're back with VoLift again, with a new needle. Perfect. So Danielle really kindly changed the needle for me, and the reason for that is I've been on the bone. Why would I take a needle, a 30 gauge, which has been on the bone and already blunted, and start to put it into an area which is full of nerves and blood vessels? I'm much more likely to cause a bruise. So now, here, look, guys, look at the eyes now. You see what happened to her left eye? it just starts to look more attractive. And this is because we're supporting the tissue of the lower eyelid and also the structures which give pillar support to the lower eyelid. So this is the injection point for the deposit of product, and I'm going to go a little bit steeper. So I want to get to the target, which is the SOOF. So skin, and then I'm just going to pop through the muscle. There we go. I'm into the SOOF now, and I'm not going to touch the bone. Aspirate, and then I'm going to inject 0.05 to 0.1 maximum. Now, after I've done that injection, I want to mold that material upwards. You see, now there is no result. That's very important. Now I'm going to take the product and I'm going to just squish this and mold it upwards through the SOOF, and I'm going to fix her tear trough in directly without the need to take the needle directly into that very sensitive anatomical area. Right, now we can do a little comparison. Thanks, darling. So if I rotate her this way, we can look at the tear trough. Here it is on the untreated side. Look at me. Perfect. Deep, and then look at the extension into the lateral lid cheek junction with a negative lateral canthus and an extension of the mid-cheek groove. Do you see what happens? So we reduce the problem by solving the cause, and that's just medicine. It's dealing with the disease rather than the symptom. Okay, now let's deal with the alar base and also at the piriform here to give better support to the upper part of the nasolabial fold, but also to give support for the upper lip here. So back to VoLift, thank you. Thanks very much. So we're going to take the product now. This is really important, so we're going to have to go deep. This is the location for the injection, and look, I'm going to be therefore medial to where the artery is and also to where the nasolabial fat compartment is. So I'm going to open her up there, and I'm going to inject at the base of the pyramid and skin. Now I'm through the levator labii superioris muscle, and then I'm on the periosteum. Two-handed approach, so always fix. And then in this location, when you're fixed, take the big bubble. Hold the bubble for at least a second, because sometimes you need negative pressure to be able to aspirate if you are in a risk area. And then the maximum injection volume here should be 0.3 cc. Should probably need around 0.2. Let's see what happens. You can start to see the upper lip is now becoming more stable, but also that the nasolabial fold is also being corrected. So actually this was 0.25 for her. Nice slow injection as well, so it's comfortable for her. And now with this again, I'm going to mold, and I'm just going to fix this into position. See, the upper lip rises when I do that, and the nostril becomes higher on one side, and also I'm going to compress the nostril slightly to allow, you see how, look with the nose now, the nose is being pushed in this direction. Can you see this three-dimensional force that's being created? And that is how you narrow a nose during aging, is take the base of the alar dome on the piriform and push it upwards and outwards. In fact, I better make a damn good job of the other side because she's actually being completely distorted from the midline here. So the summary of that is that ultimately the nasal tip will start to become better supported. I'll show more nostril. I'll have a better continuum between the upper lip and then the cheek. Whereas on this side, take a look at this. Can you see the depth of the nasolabial fold, the heaviness of the nasolabial fat compartment, the elongation of the upper lip, and the closure of the nostril? Take a look at this side now. Can you see the difference? Right. So I think that's an important point, important injection point for a variety of different reasons. Would you agree with me that on her left side now, the upper lip, I know she has an asymmetry because of the surgery, but she has almost a snarl of the left upper lip. It looks like it's been riding high, and that's because I've tented the levator labii superioris muscle. Now we're going to go to oral commissure here with VoLift. Thank you. So this, for me, oral commissure, is actually a complex of commissure to the lateral extension of the horizontal groove from labiomental crease to the prejowl sulcus. And we're going to go from superficial to intermediate to deep and superperiosteal at this area. So let's see if we can start to lift that corner of the mouth. So superficial, so this is intradermal injection or just subcutaneous. And as I inject, I come backwards. You'll start to see that the corner of the mouth will start to rise up nicely. I don't just leave it at this, because what I'm going to do now is I'm going to give a little vertical tenting support. Do you agree with me that the right corner of her mouth is sad, the left corner of her mouth is happy? Do you understand what I'm saying about facial posture and how we can make people look from being unhappy into happy, just like the emoji? So then we lift up the corner of the mouth from the vertical axis, and that's because there is a deficiency through this vertical axis. So I just put a little reverse cone with the widest part of the cone at the top, the thinnest part at the bottom. Now it starts to get really impressive. But watch this, it gets even better, because when I touch the pre-gel sulcus here, do you see how the corner of the mouth comes up? Let's do it again. You see the support that's offered from here, but I'm not injecting directly, it's an indirect effect. So now what we'll see is as we go down, the corner of the mouth will start to rise even more. So we're going to go a little deeper. So I'm now subcutaneous at this level, and always anterior to the mandibular retaining ligament, so in front there. I'm going a little bit deeper now, so this is at the same level as the muscle, the DAO. Now I'm going to go behind the muscle, and we're not touching the bone yet, but I'm getting there. Linear threads. Notice how I'm not aspirating here. Do you see this? Because just like this technique where if you move the needle, what is the point in the aspiration? But if you stick the needle fixed, then you've got to aspirate that. When I mold and conform this, look at the corner of the mouth. Just watch this again. So the corner of the mouth goes up when I just touch it like this. And that's the mechanism of vertical support. Look at the stability of this tissue now when I stress it, versus this side, if I stress it, look at this, very weak. And if I stress this side again, stable. Show me a kiss. Can you see the deformity of the tissue on this side and the stability of the tissue on this side? Yeah? Resting and dynamic solutions. So now we're going to treat the pre-jowl sulcus. There's a little bit of concavity just there. So onto the inferior border of the mandible. Now in this case, look, there's still a bit of red mark where the pencil was, and this is where I'm going to be on the periosteum, but it's high risk because you have got marginal mandibular. So there's the bubble. And then here we go with the injection. And this will take potentially 0.2 to 0.3 cc, but I think we'll do 0.2 and we'll just evaluate the result. So we're going to take the product, and if you're going to mold it, you always mold anteriorly, so not posteriorly. So why is that? Because I don't want to take the material and put it into the jowl fat, do I? So now we have a really nice result for the jawline here. So new needle, thanks. Now if I have a look at her animating, show me a kiss. Relax. Kiss. Look at the deformity here, and look at the smoothness on the treated side, and relax. Let's go a little wider, Chris. Stop. With the chin, please. Thank you. Can you see how she has a hill and a valley and a hill, and then she loses the angle of the jaw here? Because I lifted her from back here already, she became tighter through the jawline. But now I plug the pre-jowl sulcus, I make a better union between the chin through to the jaw. And if I rotate you like this, a beautiful straight jawline now, which is in keeping exactly with 40 or maybe 35. And now when I rotate like this, can you see how now she's hanging? This is the jowl fat. This is pre-jowl sulcus, the concavity anterior to the mandibular ligament. So she has here a hill, a valley, a hill, and a valley, and then a little hill because she has a little descent of the temporobuccal fat. So in making a straight jawline, I'm now giving the illusion of a slightly more youthful lower third of the face. Let's tighten her up a little bit more by injecting here at the angle of the mandible. I'm going to then the skin and then attach it more posteriorly like so. This is the bony landmark, and I want it 1 centimeter superior immediately like this. So actually with Volift, thanks, sorry. That's fine, as it is. Perfect. Right, so just so that you can see, I'm going to just pinch the skin like this, because normally I do this view, which is no good for you, is it? You can't see anything. So I'm going to just pinch the skin up like this. I'm going to show you where it would be, so it's 1 centimeter superior medial to the angle of the mandible. And as I pinch the skin up here, then I'm separating the skin away from the SMAS, but also from the masseter muscle, and therefore from risk. So this is a subcutaneous injection, aspirate, relax, and then I release with the non-dominant finger, and then I can freely inject. And this is 0.1 to 0.2 cc. Now as I come out, again, there's no result. But what I do is I give a slight little projection point for the angle of the mandible. What I'm going to do now is where the magic happens, is where I stick the skin onto the ramus of the mandible like this. Thanks. And when I do that, I should start to see that this point here has an indirect relationship with the oral commissure. It also starts to help with the marionette line. It also starts to help with the pregal sulcus. So we're starting to make individual points working as a team together, and everything is behaving in one single cohesive unit. Once that little bleb has disappeared, then the job is done. Just give me a little wider shot than that, Chris. Stop. Thank you. Let's take a look at the youthful jawline that's recreated simply by injecting 1 and 2 and then 3, but also plugging the pregal sulcus and then connecting the chin into the lower third of the face, connecting the upper lip into the central part of the face. And then we have a look at the untreated side here. You can see the more aged negative vectors that are involved with hollowing and excess, and then hollowing and excess in this area. Okay.